Namaste, it's 6:30 a.m. in LA and Vancouver, 9:30 a.m. in New York. Good morning to our colleagues in the United States and Canada, 2:30 p.m. in London, and 3:30 p.m. in Europe. Good afternoon to our friends in Europe, 7 p.m. in India, 9:30 p.m. in Singapore and Malaysia. Good evening to our colleagues in Asia, and at 11:30 p.m. it's really late at night. Warm welcome to our colleagues in Australia. I'd like to welcome all our friends who've joined us from across the globe. We have now over the last few months have had colleagues join us from more than 40 countries. I am Anupam Sibal, the president of GAPIO. I work as a pediatric gastroenterologist and the group medical director of Apollo Hospitals. For those who are joining for the first time, the Global Indian Physician COVID-19 Collaborative was established on 11th of April to bring together 1.4 million physicians of Indian origin across the globe on one platform. GAPIO now has members from 49 countries. Well, we have crossed 250 days since the COVID pandemic was first identified. As we all know, it has had a huge impact with patients being reported from more than 200 countries and territories. As of today, we have 32.8 million cases and sadly, very close to 1 million deaths. Of course, an explosion of knowledge like never before has taken place, and we now have, and you'll be surprised, 57,962 papers that have been published on COVID-19, and these include 3,333 from India. So when we look at the kind of knowledge that we have to sort of keep ourselves abreast of, it's an amazing 214 papers on COVID published every day. And I'm talking about peer-reviewed publications. Today, we'll be discussing the importance of and relevance of adult vaccination in COVID times. We have a stellar group of experts, and I'm going to ask our distinguished colleague, Dr. N.K. Ganguly, to give his opening remarks. Everyone knows Dr. Ganguly. He was a former Director General of the Indian Council of Medical Research, has been President of JIPMA, has been President of the Asian Institute of Public Health in Bhubaneswar, has more than 775 research papers. And I say that again, and I pause, 775 published papers, which is absolutely awesome. He's currently a member of the high-level committee under the chairman of the Honorable Union Health Minister for review of the evolving scenario of COVID-19. He's currently the president of the Apollo Hospitals Education and Research Foundation and guides research across Apollo, and has been awarded the Padma Bhushan by the government of India. Over to you, Professor Ganguly, please, for your opening remarks. Thank you.
Thank you, Dr. Anupam, and thank you, Ramesh Bhai. Actually, in India, the adult vaccination is an alien concept. 2 mothers' vaccinations are delivered, but essentially the adult population has been forgotten or left aside. To correct that, we recently, with the API, Association of India, we have written a book on adult vaccination covering every aspect of that. I'm chair of that, and Dr. Agam Vora is the main writer, and it is being published by Wiley. I have made the first draft available to Dr. Sibbal, and this might be available to others, but the final draft will be, our final book will be out in few months' time. In the major problem which we will be facing during COVID time in adult vaccine is the pneumococcal vaccines. Pneumococcal vaccine, the Hib vaccine, as well as influenza vaccines. Because influenza season is coming, and there are vaccine producers in India, apart from the international vaccine producers, but all the vaccine to adult population goes through private market. There is no government program for that. And people are very, very frustrated around that. And recently, the WHO has just given the names of the quadrivalent vaccine, which is changed, and we are not even ready for that. So many people are coming to me and asking that which vaccine shall we use? Where do we get that vaccine? Because the adult population in India at the moment is very, very perturbed that how do we get the influenza vaccine or a flu vaccine, because there will be a double whammy come the November when the peak season for the influenza will come in. And these guys die because they are affected by a bacterial infection known as Klebsiella pneumoniae, and there is no treatment for Klebsiella pneumoniae at the moment in India. Some are cholesterol sensitive, but otherwise most are multi-drug resistant. In this session, the main problem is that if we have a COVID vaccine, it was a nightmare for me that how the distribution will happen along with the influenza vaccine. I see this as an opportunity because this will be the first adult vaccine in the world which will go to entire population. Ultimately, it will go to children also. So there is no vaccine which goes to entire population. So the distribution as well as going to the last point would be a nightmare. And the main challenges which were there, that some of the vaccines like the messenger RNA vaccine had to be frozen at minus 90 degrees and have to be transported, and a huge cold chain issues were there. Messenger RNA vaccines have to be given 28 days apart. We didn't know that how do we handle that particular thing in a program where we reach every individual. Although a priority has been done for everyone is not going to get, 20% of the population is going to get it, but even then it is nightmare. There is one more thing which will be competing with this. This will be one of the children's vaccine, that is the hexavalent polio vaccine. Because if we miss hexavalent polio vaccine, we will have another outbreak of polio globally, because it is there in the Afghanistan and Pakistan, although Africa has become free. But if there is polio in any place, there will be an issue. So this will be competing with the COVID vaccine. So now we have a very good news coming out of the COVID vaccine. The Johnson & Johnson's vaccine, which will be manufactured by the Biological E in India, at this given moment, 1,000 persons have been done up to 55 and above 65. And this doesn't need a cold chain. This can go at 2 to 8 degrees centigrade, which is most of the Indian vaccines which are stored, and this cold chain is available. There's also a single shot vaccine. You don't need a double shot at this given moment. So now I can really visualize a distribution chain and how it will reach to people. However, not everything is hunky-dory. There are some reaction on the people above 65, or they might not give that nice and neutralizing antibodies, but up to now neutralizing antibodies are there. So it is going to 60,000 people. It will be little late. But this will be really a saver. Previously, only the Russian vaccine was like this because it is a freeze-dried vaccine. However, the confidence in Russian vaccine is very, very low, and it can't go through the adult vaccine program. So there are many candidates on adult vaccine. Some of them will be discussed here today. This will be a learning curve. While we are introducing COVID vaccine, which is bound to be introduced, there is no doubt about it. We will know how to introduce influenza flu vaccines as well as other pneumonia vaccines. We will also learn how to introduce other adult vaccine through program. At the moment, these are only available through the private chain, and this is very, very difficult because private chain is utilized by 330 million Indians who can afford treatment anywhere. They can even afford treatment in United States without insurance. However, 8 or 900 million Indians who are really poor or marginal or middle class, they have to be supported through programs. So I wish that the thinking with this particular symposium will bring in will go ultimately a long way to learn and introduce adult vaccines riding on the COVID vaccine introduction experience. Thank you.
Thank
very
you
much.
so much, Professor Ganguly, for highlighting the need for us to build a program around adult vaccination, because we will soon have to have one for COVID. I hasten to add that we will not be talking about COVID vaccination at all today. We have an absolutely brilliant program coming up on 10th of October, where we are going to have the experts who are actually involved in the trial. So we're going to have someone from Oxford, someone from the US talk about the US vaccines. We're going to have someone from Moscow talk to us about the Russian vaccine. And we're going to have Dr. Vinod Paul summarizing all the developments with the Indian vaccine. And we'll also have a presentation on the Chinese vaccines. So that's for 10th of October. But Dr. Ganguly highlighted the need for us to look at flu, look at pneumococcal, and see how is it that we can discuss, one, the importance of this vaccination, and two, how is it that we can make it available. So we start off with the first presentation, and it's a privilege to introduce my esteemed colleague, Dr. Sudhir Parekh. Dr. Sudhir Parekh is a well-known expert in immunology and allergy based out of New York. He is also the chairman and publisher of Parekh Worldwide Media and ITV Gold 24/7 television channel in US. And through his publications and through his media house, Dr. Parekh reaches out to more non-resident Indians than any other organization. Many honors have come Dr. Sudhir Parekh's way. These include the Padam Shri, the Pravasi Bharatiya Samman, the Ellis Island Medal, and the title of the Knights of Malta. Over to you, Dr. Sudhir Parekh. Dr. Sudhir Parekh, please. Unmute yourself, Sudhir bhai.
Hello.
Yes.
Hello, dear friends. Good evening and good morning to everyone. It's really an honor and privilege to introduce Dr. Vinay Devraj, who has done his internal medicine from Chandigarh and he's specialized in infectious disease from Chennai. Dr. Vinay is the head of the infectious disease and vaccinology and travel medicine at Apollo Bangalore. Dr. Vinay also a convener of dedicated adult vaccination program or center at the Apollo Hospital in Bangalore. He has published more than 15 papers in the indexed journals, and he is expert in the vaccination and vaccinology. Let's welcome Dr. Vinay Devraj. Dr. Devraj.
Thank you. Thanks to Gapio. And without wasting much time, let me start sharing my screen. Right. Okay. So if I could, I'll jump straight into the topic, which is influenza vaccination in adults in the COVID era. As we know, influenza A and B are the most pathogenic of all the influenza strains which affect the humans, and they are distributed across the world in varied formulation, with influenza A and influenza B in equal numbers of late. There are minor antigenic variations which can result in antigenic drift that we have read of, and major antigenic variations result in antigenic shift, and consequently there can be pandemics. In the recurring soap opera of pandemics, influenza has had the maximum screen time and has killed the most people compared to any other disease in the last 5 centuries. It continues to do so. It is a disease with high impact, high incidence, and high mortality. So over a period of next 5 to 6 minutes, my effort will be to try and convince you as to why influenza is important in the COVID era and why influenza vaccination is even more important in the COVID era. Talking about mortality, mortality is merely the tip of this giant Everest. Bulk of cases are due to lack of adequate lifestyle and impairment in lifestyle that result in influenza or result due to influenza. As is shown by the CDC estimate that for a short period of 3.5 months between October 2019 and February 2020, there were close to 30 million cases of influenza and its complication and close to 16,000 deaths. This is in concordance with the WHO estimate that there is possible 3 lakh to 6.5 lakh deaths that can occur directly due to influenza and its complication. So these words and figures themselves speak of the high impact that the disease has. It is paradoxical that the recording of such disease and the events, complications, deaths that result due to influenza in India is much lesser what is seen with the world. But we are always in the vein of underreporting and under-recognizing. So it is possible that influenza, its complications and deaths are much, much more in India than what is recorded by the national centers and so on. Influenza is a disease with huge set of complications which are both short-term and long-term. One of the complications that was highlighted by Professor Ganguly is, apart from direct complications that influenza causes, it also attracts secondary bacterial infections, and it causes a lot of haywire in the antibiotic stewardship program worldwide. Pneumococcus, MRSA, Klebsiella are noteworthy secondary infections which follow influenza. So influenza per se is not just directly influencing the health, it also induces secondary bacterial infections which causes great morbidity and mortality. There are various high-risk groups which are at highest risk of influenza, those which are in immunocompromised conditions, those which are on immunocompromising therapy, and mainly in the common populace, the patients with long-term or chronic lung, liver, kidney, and heart conditions are at maximum risk of influenza, and them along with pregnant women, too younger age group, too old, and the healthcare workers constitute the most eligible candidates for influenza vaccination, because this is the group which is at maximum risk of influenza and its complication. It doesn't mean that these are the only groups which are to be vaccinated. In simple terms, what CDC says and rightfully says is anyone and everyone above the age of 6 months should be offered and given the flu vaccine. For the reason that, as facts and figures clearly prove, influenza vaccine helps preventing influenza, which is by and large an easily vaccine preventable disease. If influenza vaccine works well, lot of morbidity and mortality can clearly be prevented. Apart from that, influenza vaccine induces a extensive herd immunity. More the number of people you vaccinate, more the high risk groups or the vulnerable groups get protected. So influenza is one such vaccine where vaccinating not just helps the high risk groups, but also every other age group, thus forming a good barrier of herd immunity, which is now come into picture thanks to COVID. Influenza vaccine is not a vaccine with 100% effectiveness. What I mean by that, not everyone who gets vaccinated escapes disease. You must still have the disease at the end of the day after getting vaccinated, but the intensity and severity of the disease is much, much lesser in a vaccinated individual, and the risk of death is greatly reduced by influenza vaccine. That is the biggest advantage of influenza vaccine, and for that reason, influenza is to be widely made use of. There are different types of influenza vaccine. The killed inactivated ones are the ones which are mostly made use of, and there are hardly any contraindications for the killed inactivated vaccine. Anyone and everyone above the age of 6 months can get this vaccine. There are certain contraindications, mainly immunocompromise and pregnancy, to the live vaccine. Depending on how they are produced, the influenza vaccine can be egg-derived, cell-derived, or recombinant. If there are 2 influenza A and 2 influenza B, they're called quadrivalent vaccines, whereas 2 influenza A and 1 influenza B, they're called trivalent vaccines. When it comes to timing of the vaccine, India belongs to the southern hemispheric strain. That is, depending on what is the more prevalent strains of the influenza in the given year, WHO predicts what could be the best strain of vaccine to be given. India belongs to the southern hemispheric strain, and WHO suggests vaccination in the month of April. But as we know, bulk of areas, regions, states, and centers in India, the problem of influenza is perennial. So rather than waiting for the trigger of monsoon or winter, after which influenza outbreaks happen, it is ideal to vaccinate at any point of time in the year. Remember, influenza vaccine is once a year, the protection is annual. Do not wait for a trigger. You can vaccinate particularly the vulnerable groups or the high-risk groups at any point of time when they come in contact with you. The dose is 0.25 ml for children less than 3 years. Anyone above the age of 3 years, it is 0.5 ml, and it is intramuscular for killed inactivated vaccines. Much is spoken about the adverse effects. We just discussed about the possible efficacy and effectiveness of the vaccine. It is a safe and effective vaccine, but much is spoken about the possible side effects and adverse effects. There are many literature which clearly show influenza by and large is safe. If you take into account this cohort, a huge cohort over 9 years in UK, it clearly showed all these possible minor side effects are short-lived and they recover self, whereas the major dreaded adverse effects of Guillain-Barré syndrome and egg allergy-induced anaphylaxis are much, much lesser compared to the disease itself. That means those who have the disease are at greater risk of side effects and adverse effects than the vaccine. For this reason, CDC does not or has not changed its 2017 and 2018 directive, wherein anybody with a known, possible or anticipated adverse effect of egg allergy can also take any of the influenza vaccines. Unless until you had any life-threatening anaphylaxis, influenza vaccine is not a contraindication. The only necessity is get vaccinated in a safe environment where you can be monitored for at least 30 minutes. It's by and large a safe vaccine. So among the trivalent and quadrivalent vaccines which are available, so what is more preferred? Earlier studies possibly stated that there was no benefit of quadrivalent vaccine over trivalent vaccine. But of late, from the year 2018 onwards, since there is more and more influenza B, which is prevalent, quadrivalent vaccine, as per studies, seems to have an edge over trivalent vaccine. Now, influenza more than ever is now relevant in the COVID era. Similar illness, similar type of presentation, but lesser morbidity and lesser death compared to COVID. But the importance of influenza in the COVID era is that there is a higher chance of influenza concurrently occurring with COVID. And a lot of studies have proven and or have presumed that with the presence of influenza concurrently, COVID can accelerate itself and a lot of cases might end up in death. So for this reason, influenza, with all the rules which we spoke about, the rules of the game remain the same. It is a safe vaccine, it's an effective vaccine, and it is necessary before the possible twindemic sets in, before the outbreak of influenza happens. It is safe for us to vaccinate ourselves. Simple rules are to be followed when it comes to infection control, not going into detail of that. So all physical distancing and safety measures, if instituted, influenza vaccine can be safely administered and the possibility of outbreak of influenza can be reduced, and influenza related enhancement and worsening of COVID can thus be prevented. So it's a safe vaccine. What I would suggest is get vaccinated and stay healthy. Thank you.
Thank you so much, Vinay. That was absolutely brilliant, to the point. And you stuck to the time given. We're going to do a Q&A later. Thank you so much, Sudhir Bhai. We move on to the next session, and it is an honor for me to introduce Dr. Ramesh Mehta. Dr. Ramesh Mehta is a distinguished pediatrician, very closely associated with the Royal College of Pediatrics and Child Health and responsible for bringing that exam to India. He established BAPIO and is the president of the British Association of Physicians of Indian Origin. He's the immediate past president of GAPIO, has been honored by the Queen with an OBE. Over to you, Dr. Ramesh Mehta, to introduce another Dr. Mehta, Dr. Ravindra Mehta.
Thanks, Anupam. Hi, everybody from rainy and cold London. I'm sure the weather is better in India. It's my pleasure and delight to introduce my namesake, Dr. Ravi Mehta, who is a senior consultant and interventional pulmonologist at Apollo Hospitals, Jayanagar, Bangalore. He is board certified from America, and he is an established clinician, researcher, and a teacher in the field of pulmonology and sleep disorder medicine. Dr. Mehta is an extensive academic training and professional experience from USA. Dr. Ravi Mehta. Thank you.
Thank you very much. And it's a pleasure to be here again. And of course, the co-meta thing is always good, as the co-vaccine, which was talked about. I'll just share my screen quickly and we will start the session. 1 second. Okay, so basically we're talking on pneumococcal vaccination, and Vinay set the stage very nicely with influenza, which has been something much closer to the current pandemic. And we will take it on to pneumococcal vaccination, and establish strategy with enhanced relevance in the current COVID pandemic. Maybe not so directly, but because every vaccine of significance has somehow been brought to the forefront with COVID in the hope that something helps. Not this one, however, but the co-infection paradigm always stays true when it comes to vaccination. Here you can see a scanning electron microscope of the pneumococcus, and this is what has been the bane of existence for many years, with a huge burden in worldwide literature. The causative organism of pneumococcal infection, Streptococcus pneumonia. Again, the picture is shown over here. The interesting part is that it really has many types out here. So just like we're trying to figure out COVID types, this has 90 known serotypes. The good part is that not all of them are bad. A lot of them are just good basic science. Around 27 of them account for around 90% of the most frequent isolates, which has made the science mature enough to think of how to prevent it using vaccine targets, which comes down to why even think of vaccination. The disease has to be bad, severe, or widespread enough to so as to have an impact with vaccination. Here, pneumococcal disease is either non-invasive, the not so bad stuff which we have learned to live with. Of course, pneumonia being the worst element over here, but then the pneumonia part of it can spill over into metastatic manifestations to the bloodstream, and dreaded bacteremia, worsening meningitis, and other metastatic manifestations define the life-threatening impact of invasive pneumococcal disease. The key part over here is that, unlike just like other disorders, the non-invasive element becoming invasive is not very evident. So obviously targets are oriented towards taking both into perspective. And since the differentiation is often not clear, it becomes important to try and prevent it in a bigger way. Data which has come maturely, and I think 2 decades from now we'll be maybe talking of all the other COVID data as it comes in. Risk of invasive pneumococcal disease is around 5.6 is a relative risk, which is very high, and it comes with the corresponding mortality. And so this sets the stage that in chronic lung disease, you have to actually at least think of a higher level of precautions. And that is why an unambiguous clarion call has come from WHO that prevention of pneumococcal disease is a preventable target and a benchmark everywhere in both industrialized and developing countries. And which brings us to the vaccines available. So we have pneumococcal polysaccharide vaccine, the first one which came when Michael Simbakov from the New York Veterans Administration published in 1986 the NEGM cornerstone paper, the 23-valent polysaccharide antigen vaccine, which took care of 23 of the 27. And it took care of quite a bit of infection, but there was a problem with diminished immunogenicity with age. And this was going on for many years. Till a few years ago, we had a different vaccine. So this polysaccharide vaccine came with the fact that there was not much of a T cell response. There was immunological incomplete, and it was nothing which had a memory for long-term infection. So obviously ongoing research went on to have a better substitute or a better compatriot at least. And the pneumococcal conjugate vaccine, especially with its role in children, the famous word of T-cell immunity came up over there, which has also been very important in COVID times. And of course, the advantage was that since we gave it to children, it reduced nasal colonization, eliminated it, and indirect herd protection, all very, very important terms at this point. And that is why this particular vaccine came up very fast, and it has been adopted very quickly in the developed countries, and of course needs to be or is being adopted in underdeveloped or developing nations. And so here, this complex picture, which I'll not dwell on in detail, shows you the most important part of effective B cell and T cell activation, which is not only going to cause a better immune response, but also a lasting one, which is very important when you have any vaccination paradigm in your target. These are the landmark papers out here, which basically set the stage for the the conjugate vaccine. And this is what's called the Capita paper, which came in NEGM in 2015. And a bunch of them came from other societies, which also not only reiterated, but validated and reinforced the importance of this vaccine. Then came the recommendations, which I think are maximum in vaccinology. And abroad, there were multiple recommendations, ACIP being the most common and the most spoken about. And Indian vaccination guidelines came very swiftly from the Indian societies. Then to go over some of the major vaccine recommendations out here, for adults I'm talking and not the pediatric population, ACIP says, of course, you must think of the 13-valent and the 23-valent in a certain fashion. And they went on to make something which is slightly confusing for a 7-minute talk, but nevertheless, we must talk about, is anybody who has any impairment of the immune system or immunosuppression or disease paradigms which may cause you to be more susceptible to pneumococcal infection should be getting, initially they said PCV13, followed later by the PPSV or the 23-valent. However, this has been revised and we'll talk about it in the end. And this was because it came down to the fact that the risk group, now over time the science became more refined, the risk group was different for PCV13 and PPSV13. I'll be happy to share these slides if anybody wants them. In such a situation, for the worst population, clearly by vaccination made sense. But for people with other areas, it became a shared decision that you may or may not give it. And I will add a personal reminder, shared decision means that most practitioners will give it because most patients will be willing to take vaccination when they have a certain susceptible disease profile. Indian guidelines follow suit over here, and I have the pulmonary guidelines out here. They were firm and said that we need both vaccines. There's no shared decision making out here. We're quite paternalistic and firm looking at our considerably problematic situation. And they clearly mentioned over here in this guideline, where our co-host Sushmita is also part of this guideline, that we should give both vaccines because the herd immunity which PCV13 has induced in the Western population is not part of an Indian luck faction. So we have to sequentially give both vaccines to have the maximum benefit of this particular entity. And so the paradigm here, which can be confusing to first-time listeners, to cut a long story short, is always give PCV13 first, and 8 weeks later you can give PPSV after that. And of course, if there's mixes and matches depending on who has got first, which I will not dwell on in detail, but we'll throw out this chart over here, which basically gives you a full plan for if you have not received any vaccine, if you've got PPSV first, if you've got PCV13 first, and so on and so forth. So bottom line is that it's not that challenging, but it has to be incorporated into some sort of checklist to make sure that the vaccination paradigms are given correctly. So to summarize the whole talk, certainly pneumococcal infections are here to stay, and they have this co-dance with influenza also. Certainly immunocompromise, which we have introduced in our healthcare because of our therapies and age, is a target for all this. The two vaccines which came in the last 35 years are the conventional polysaccharide vaccine and superior representative, the conjugate vaccine. The algorithms are available and can be shared depending on the status of the patient, and the guidelines don't differ too much. In the Indian guidelines for now say that do use both vaccines sequentially to have the maximum immunogenic anti-pneumococcal protection which you can gather. Thank you very much for the attention.
Thank you so much, Ravinder, and thank you so much, Dr. Ramesh Mehta. We now move on to the next talk, and this is going to be on TTP. And to introduce the speaker, I'm going to now call upon Dr. Rohini Sridhar, who is Chief Operating Officer of Apollo Hospitals in the Madurai region, looking after 4 hospitals. She is one of the key members of the Women's Forum of GAPIO and is the Joint Secretary of GAPIO. Over to you, Dr. Rohini.
Thank you, Dr. Anupam. It is my privilege to introduce Dr. Ashok Datta, who's the Emeritus Consultant at Apollo Hospital, Delhi. He's the former Director, Professor, and Head of Lady Hardinge Medical College, New Delhi, and has over 45 years of experience in teaching and research. He's a member of the Indian Expert Group for Polio Eradication and the Indo-US Research Group. He has over 175 publications to his credit in both national and international journals, and has edited several books, including a book on immunization. He's the recipient of several distinguished awards, including the Outstanding Asian Pediatrician Award from the Asian Pediatric Society and the Lifetime Achievement Award from the National Neonatology Forum of India. And we will be privileged to listen to Dr. Ashok Datta speak to us on the Tdap vaccine. Over to Dr. Datta.
Thank you very much, Dr. Rohini, for this introduction. Good afternoon, good evening, and good morning to various listeners all over the world. And today I am going to talk to you regarding a vaccine which is not very well known to people. I'm just sharing my screen. So this is the Tdap vaccine I'm going to talk to today. The world's oldest vaccine, which is invented and perfected by Sir Edward Jenner, has not been developed for children alone. The first 3 vaccinations which were developed, 3 or 4 vaccines like smallpox, rabies, typhoid, plague, and cholera all started with adult range of vaccines, and then the other vaccines which were developed later on. Ultimately, the vaccination became a domain of pediatrician because of increased infant mortality, and most of the countries, they adopted a national immunization program which included only mostly in children. And then later on in some of the countries, the adolescent vaccinations came, and some of the countries, the adult vaccination came forward. But so far in India, we are not having a national schedule so far as an adult vaccination program is concerned. There are many diseases which can be prevented from adults, and you can see that there are so many diseases, 14 deadly diseases which can be prevented in adults. I am unable to shift, I do not know why.
It was working all right till a minute ago. Let's give it a second.
In the 1 minute ago it was all right, but now I am unable to shift my slides.
Can you, are you able to see the icon that you have to press?
I am seeing.
You want to go back and see if you can go back and then move forward?
I'll just stop share and then again I'll go.
Yeah.
And then I'll be able to do it most possibly. Can you see my?
Yeah, we can.
Okay. Now I would like to tell that there are so many 3 vaccines, basically diphtheria, pertussis, and tetanus. And you can find that as a combination DPT, DT, DTAP, Tdap, and TD. These are the different combinations which are there. The first one is the DPT, which is the age-old vaccines, which contains full dose of diphtheria toxoid, full dose of pertussis, whole cell pertussis, and full dose of tetanus toxoid. And here the pertussis component is absent because in some conditions where pertussis is not to be given because there are some contraindication in which only DT has to be given. Then came the acellular pertussis containing diphtheria and tetanus toxoid because there is an increased reactogenicity of pertussis vaccine, and as a result the acellular pertussis vaccine was invented, and that the first vaccine, monovalent acellular pertussis vaccine, was developed first in Japan. And then Japanese government did not allow this vaccine to do a trial, clinical trial, and then the Swedish people, they took up this particular trial. They found it to be very effective, and since then acellular pertussis containing DPT is in use in most of the national program in all developed countries of the world. Tdap vaccine is one where there is tetanus is the full dose, diphtheria content is less, and even the acellular pertussis content is lesser than what it is there in the DTAP vaccine. Because after the age of 6 years, you cannot use either a DPT whole cell or even you cannot use a DTAP vaccine, and it is only Tdap vaccine which can be used in children above the age of 6 years as well as in adults. And in some cases, TD vaccines are being used in some of the programs because AP containing vaccines are very costly, and that is the reason only TD vaccines are used, especially in India, in the program itself. Now, if you look at the basic difference between the DAPT and Tdap vaccine, which is an adult vaccine, older children and adult vaccine, the tetanus toxoid content in all vaccines are same, which is 5 Loflat dose, LF dose, or 54 international units. Diphtheria content, you find that there are preparations which are available in India, hexaxim, pentaxim, tetraxim, or infenrix hexa. All are DAPT combination, acellular pertussis component containing D and T. And you find that all are having at least 20 international units. If you come to Tdap vaccine, you just see the diphtheria content is only 2 LF or not less than 2 international unit, which is less than 2.5 Leffler unit in Boostrix and Adacel. These are the two preparations which are available all over the world. Pertussis toxin content, you find that in all those vaccines it is 25 microgram, whereas you find in Adacel it is only 2.5 microgram and 8 microgram in Boostrix. There are other components in the cellular pertussis content, which is filamentous hemagglutinin, partectin, fimbrial antigen 2 and fimbrial antigen 3. These are available in Adacel, but fimbrial antigen 2 and 3 are not available with Boostrix. But anyway, only the pertussis toxin, which is the most important part of this acellular pertussis vaccine. So even a monovalent, bivalent, trivalent, or even pentavalent pertussis toxin, pertussis containing a cellular component is good enough for giving immunity. If you come to the epidemiology of pertussis, pertussis is endemic in almost all countries of the world, and recently there has been an outbreak of pertussis in some of the countries, including USA, UK, Australia, and many other countries. Periodic outbreaks at all age groups are known. Newborns and partially vaccinated infants are at risk. Pertussis is underdiagnosed, underreported, with wide range of symptoms because the investigation is very, very difficult. RT-PCR is the gold standard for it, and which is very, very difficult to do, especially in developing countries of the world, including India. Older children and adults act as reservoir for transmission to susceptible infants, and that is what it is very important. Under the age of 2 months, these are very important cause of mortality under the age of 2 months. If you look at the number of cases of diphtheria as well as tetanus, you find that the largest burden of the world in India is India. 9,622 reported cases are there of diphtheria, as well as there are a large number of cases of tetanus which is being reported in India. And these all cases of tetanus which you are showing in this particular slide are of adults. Pertussis is, of course, US is showing much higher than, and some other countries are showing higher than in India. Now coming to the impact of vaccination, if you have low child vaccine coverage, you will find that incidence of the disease will be high incidence in late infancy, early childhood pertussis, frequent natural booster is there, immunity boosted in adolescent and adults, and most disease occur in early childhood. This occurs in many developing countries of the world. With a high child vaccine coverage, like DPT coverage is very, very high. Even the world DPT coverage is almost 86%. And even in India, it is also the 3-dose DPT coverage is more than 86%. So it occurs low incidence in late infancy, early childhood pertussis and early childhood pertussis, less natural boosting which is occurring, and loss of immunity in adolescent and adults, and most diseases in early infancy, adolescence, and adulthood. And this is the situation which we are reaching even in India, and most of the developed countries of the world are in this particular stage. So adolescence and adulthood, they are getting more cases of pertussis. If you look at the disease duration of protection, please remember that neither diphtheria, nor tetanus, nor pertussis, even if they suffer from the disease, they do not give a lifelong immunity. And a pertussis disease at best can duration of immunity is 10 to 15 years. If you give a wholesale pertussis vaccine containing DPT, it is 8 to 10 years. If you give a cellular pertussis vaccine, it is 5 to 7 years, more towards 5 years rather than 7 years. Following diphtheria, 10 to 15 years again. Diphtheria toxoid, detoxoid vaccine, you will find that 10 years and starts waning after 7 years. Tetanus, the immunity even after tetanus disease is nil, And tetanus toxoid vaccine, on the other hand, can give rise to 5 to 10 years of immunity after giving the vaccine. And therefore, there is a need for this boosting at time to time these vaccines. And as I have already told you, you cannot use a acellular pertussis, full dose acellular pertussis. So Tdap vaccine is the one which you can only use. And infants under the age of 1 year are the greatest risk for death and complication for pertussis. And out of that, usually you will find that less than 2 months of age are most vulnerable. It is from 2000 to 2004 in USA accounted for 92 per 100 US pertussis deaths, and risk of death is highest among youngest infant, I have already told you, under the age of 2 months, and about 60% of infants with pertussis is hospitalized. Please remember that adults transmit the disease to infants. Adults, they do not suffer from severe disease, and these are the candidates who will be transmitting, and especially the grandparents and
Dr. Datta, we've lost your audio. Dr. Datta, we've lost your audio.
they can also transmit to vulnerable patients. Or petty pertussis outbreaks is reported in pandemic and adult inpatient wards, maternity units, and obstetrics units. And infection control activities are resource intensive, disruptive, and costly. And that is why vaccination is most important. Clinical efficacy of adult acellular pertussis vaccine, that is Tdap vaccine, there is an US adult pertussis trial, a part trial which was done, and persons aged between 15 to 64 years, and they found that the vaccine efficacy is 92% with 95% confidence interval. Please remember that this particular vaccine, diphtheria, pertussis, as well as tetanus, all three vaccines are very, very immunogenic, and they give almost more than 90%. So they are excellent vaccines, unlike other vaccines. So why you need Tdap vaccine in adults? In view of the waning immunity of pertussis, diphtheria, and tetanus following primary and booster doses, high disease burden of all three diseases in adults, prevention of transmission of pertussis and diphtheria from adults to infants, especially pertussis in young infants, in pregnant women to prevent tetanus and pertussis in newborn and young infants.
Dr. Datta, we are losing your audio again.
Only for children 7 years and older. So till the age of 6 years, 11 months, 29 days, you can use DTP or DTAP. But after that, you will have to use Tdap vaccine after the age of 7 and above, including adolescents and adults. Adolescents should receive a single dose of Tdap, preferably at the age of 11 to 12 years. Pregnant women, please remember that should get 1 dose of Tdap during every pregnancy to protect the newborn from the pertussis. It is not only for her, it is for preventing the newborn from pertussis, because infants will start getting vaccination earliest at 6 weeks to 2 months in many other countries. So by the time they complete their primary immunization schedule, it will be either 6 months or 6, 10, 14 weeks. And after that, again, you require 2 weeks time for the immunity to develop, antibody to develop. So during that time, if a baby develops pertussis, it causes a lot of morbidity, and most of the mortality in pertussis is under the age of 2 to 3 months. Adults who have never received Tdap should get 1 dose of Tdap. And most of you who are today listening, I'm sure you have not received a Tdap vaccine, so you should go and get Tdap vaccine tomorrow or as early as possible. Also, adults should receive a booster dose every 10 years or earlier in the case of a severe and dirty wound or burn. I'll tell you in which case you should take even earlier than 10 years. Booster doses can be either Tdap or TD. In the year 2020, January, the ACIP recommended that it is better to give Tdap but in case Tdap is not available, then you give Td. Tdap may be given at the same time with other vaccines. So Tdap recommendations, you'll find that providers should not adult age at 65 years with Tdap. For adults not previously vaccinated with Tdap who need wound management to prevent tetanus, Tdap is preferred over Td. For adults who have received an initial dose of Tdap, Tdap may be administered in any situation where Td was previously recommended. So these are the now latest recommendation in 2020. And please remember, there is no upper age limit for Tdap vaccine, which was earlier recommended till 64 years, but now there is no age limit, and anybody who is living up to even 100 and more than that can also receive Tdap vaccines without any problem. So this is the recommendation by ASIP, which states that you can use Tdap vaccine, 1 dose of Tdap, and then either Tdap or Td, any one you can use every 10 years. Routine adult Tdap use for healthcare workers or pregnant women. Please remember, healthcare workers in hospital or ambulatory care should receive 1 dose of Tdap, irrespective of their early Td vaccine. And please remember that if they have received even Td vaccine or tetanus vaccine even maybe a few days back, they can repeat Tdap vaccine without any problem. That any gap is not required. Earlier, the gap used to be 2 years, but now the latest recommendation said there is no need for any gap to be given. Priority to healthcare provider who are in contact with infants less than 1 year. All pregnant women should receive 1 dose, as I have already told you, in each pregnancy to prevent their newborn in the first 2 to 3 months of life. And in pregnancy, it should be given between 26 to 36 or 37 weeks recommended. But in UK, they recommend that you can give it at 17 weeks to 36 weeks. Suppose they have missed during pregnancy, then you can give it even in the immediate postpartum period. And this also would prevent the onset of or occurrence of pertussis in their newborn. Please remember, this is a very important. We have always seen during our practice that most of the physician, whenever there is wound or injury, immediately there will be a tetanus toxoid will be injected. Please remember, if it is an unknown or less than 3 doses of tetanus in the primary series has been given, then if there is a clean wound, TT only, no TIG, that is no tetanus immunoglobulin. All other wounds you will have to give TT as well as tetanus immunoglobulin. If they have received less than 3, or if you know that unknown, if a person has received 3 or more than 3 doses, then you don't require to give TT unless and until it has passed more than 10 years from the last dose. If 10 years have elapsed, then you will have to give TT, but no TIG. All other wounds, you will have to give TT only if suppose 5 years have elapsed. So it is a compound wound injury where there is an infection is likelihood. If 5 years have elapsed, then only you will have to give TT, but no TIG is required. So this is the recommendation so far as TT is concerned. And please remember, in place of TT, TD is recommended in India, but it is preferred to give Tdap vaccine, which will take care of not only tetanus, diphtheria, but it will take care of even pertussis. Not only for him, it will prevent even pertussis in the young infants. So to summarize, I would like to tell that Tdap is an excellent vaccine which provides protection against tetanus, diphtheria, and pertussis. 1 dose of Tdap in adults followed by Tdap preferably, if not TD every 10 years, which is recommended by both SCP as well as CDC. In each pregnancy, 1 dose between 27 to 36 weeks. If missed, then in postnatal period to prevent early infant disease, and healthcare providers in close contact with infants should receive 1 dose of Tdap. I think I'd stop here and
Thank you so much. Thank you so much, Rohini. Thank you so much, Professor Datta. And we move on to the last talk. And then, of course, we have time for a Q&A. This talk is going to be on herpes zoster. And it's a privilege for me to introduce our moderator, Dr. Pallu Malawala from Australia. She's an ophthalmologist, originally from Ahmedabad. And she is the president of the Australian Indian Medical Graduate Association, or AIMJA. She's a founder and director of Rosal Surgery in Sydney and is actively involved in numerous health awareness programs and has been instrumental in raising funds for breast care awareness. Over to you, Pallu.
Thank you, Anupam. Thank you very much. It's my real pleasure and pride to introduce the next speaker of this meeting, Dr. Bakulesh Kamar. Today, he's going to speak on herpes zoster immunization. Dr. Kamar is the Executive Director R&D of Cadila Pharmaceuticals since 1996 and responsible for bringing great innovations at Cadila. I used to know him as a very successful ophthalmologist many years ago, and now he's excelled himself in medical research, including immunizations research, and he's specially working on an immunomodulator agent for prevention of COVID-19. Dr. Kamar, welcome to our Zoom meeting and hope to hear a lot of your achievements in the near future. Over to you, Dr. Kamar, and good morning. It's past midnight in Sydney.
So, good morning, Pallu. And I'm happy to share, as an ophthalmologist, herpes zoster was first diagnosed to be responsible for acute retinal necrosis, a dreaded disease, sight-threatening, and we are seeing it much more now than what we used to see initially. And so I'm thankful to the organizer for giving me this topic. So,
if you could be a bit louder, please.
Okay. So before I start, I'm employee of Cadila Pharma, and we work on a subunit vaccines, and we have licensed product of monovalent H1N1, trivalent seasonal, and 3-dose rabbit subunit recombinant vaccine, first time in the world, all the 3. We are also working on quadrilateral seasonal influenza, and we are also working on varicella zoster subunit vaccine. Now, why it is important to have a zoster vaccine? If you look at it, I mean, as you age, your cell-mediated immunity decreases, and your chance of getting herpes zoster increases. And this increase is not static only with the age. It is also as the time passes. So if you look at the numbers from CDC, the number across all age group were lower in 2000 compared to what it is in 2015. It is gradually increasing over time. Nobody knows why it is increasing, but it is increasing. So it is increasing with passage of time, and it is increasing with age of an individual. Now, if you look at it, by and large, herpes zoster just gives you some amount of rash, and it subsides by itself without any particular management. But why it is important? Because post-herpetic neuralgia, which happens in quite a good number, and it persists for more than 3 months, and it is devastating. And that post-herpetic neuralgia, in general population, it happens in 1 in 10 adults with herpes zoster. But if you go through the age group, it increases with the advanced age. So more at advanced age you get the disease, you are more likely to get post-herpetic neuralgia. And that in itself is an adequate indication for having a herpes zoster vaccine. But that's not adequate. I mean, there are dreaded complications, as mentioned by my previous speaker, for influenza vaccine. So you get super infections, you get pulses, and you get visceral involvement, and that is damaging. And around 1 to 4% of the people with herpes zoster gets hospitalized because of various complications. And this hospitalization rate is higher in older people, and it is significantly more in immunocompromised. And if that is not all, there is a death, which is seen in up to 0.69 per million of population. But if you look at the chart on my right side, as you age, that mortality increases. So as you age, your chance of getting herpes increases, your chance of getting post-herpetic neuralgia increases, your chance of getting hospitalization increases, and your chance of dying because of herpes increases. And I mean, people in India say that, okay, we are young people, we are a country of young individuals. But if you look at the numbers, we have more than 26 crore in this age group, which is much more than majority of the European company put together. So it is not a small problem, but it's a neglected problem for us in India. There are two types of vaccine available. One is live attenuated and another is a subunit recombinant. Live attenuated vaccine is getting discontinued from US market since July this year. It will be allowed to be sold if it is available in the pharmacies but not produced. And from December onwards, it will not be allowed to be sold in US. While subunit rabies vaccine will be the only vaccine which will be available in 2021 onwards. And next slide will tell you why it has happened. So if you look at live attenuated vaccine, first is its protective efficacy is not adequate. And protective efficacy decreases with the age, while subunit vaccine gives almost identical protection across the age. And live attenuated vaccine does not provide adequate protection for post-herpetic neuralgia. This is a major problem for adults, while subunit vaccine provides significant protection and across all age group. And the reason for this is that it is, as mentioned previously, it is a cell-mediated immune response which is responsible for acquired disease in the adult or aged people. And subunit recombinant vaccine is able to maintain cell-mediated immune responses across the age group, while live attenuated vaccine, the cell-mediated immune response decreases as the person gets aged. And that's the reason live attenuated vaccine is getting out and subunit vaccine is going to be the only vaccine available, at least in US for the time being. Now, when the vaccines are not available and still you want to use it, so what are the high risk people? So immunosuppression by any means like AIDS is a high risk. The chance, which is 1 to 4%, becomes close to 30% in these people if they develop herpes, to get complication and to get hospitalized. Immunosuppressive therapy, including chemotherapy for cancer, also predisposes these people for a herpes zoster development. And this gets more compounded when you have elderly people who is immunocompromised. The cumulative incidence is as high as 50% of getting herpes zoster lifetime, and then their chance of getting hospitalized. And patients with active lymphoproliferative malignancies has a very high rate of getting herpes zoster and getting a disseminated disease and death. So in nutshell, after 50, everybody should try to get a herpes vaccine and think as you advance. And this vaccine currently available gives a protection up to 4 to 5 years. Long-term data is not available, but live subunit vaccine is likely to give a long-term protection compared to the, subunit vaccine is likely to give you long-term protection compared to the live attenuated. Live attenuated decreases from 5 to 7 years. Thank you very much.
Thank you so much, Dr. Bakulesh, and thank you so much, Pallu. We now move on to the Q&A session. It's a privilege to introduce my colleague, Sushmita Roy Chaudhary. Sushmita is a senior consultant in pulmonology and sleep medicine, interventional pulmonology at Apollo, Calcutta. She's been very actively involved in research with IIT Kharagpur, has been a DNB teacher, and received her training in addition to India from the United Kingdom. So for anyone who wants to ask questions, please put in your comments in the chat box. And over to you, Sushmita.
Thank you, Dr. Sibyl. So really informative, I think, even for us who are practicing clinicians, and all the points, all the speakers made were good. I think I'll start. I have a few questions of mine while we wait to have questions from the audience. I'll start with Ravi. We being adult pulmonologists, we find lots of our patients who come who are completely vaccine naive, and you did touch upon the topic that when somebody is who's vaccine naive, you give them the conjugate vaccine first because it tends to produce memory. And that is why at least 8 weeks to 1 year later, you give the polysaccharide vaccine. So, with our COVID patients, we are finding a lot of patients who are coming who've never received any vaccine, and you want to give them pneumococcal vaccine. So how soon after COVID would you vaccinate the patient, and with which one first?
That's a lovely question, and it's coming from Sushmita, who was a co-author on the Indian guideline. So that's an interesting part. Now, of course, the interesting issue here is that the relationship with COVID is this multi-vaccination now. As Anupam said, or somebody was saying that flu shot has become so important that to the quadrivalent, it's running out of stock. Then comes the pneumococcal one, and everyone's asking for it right now. The question is that, is there any data? There is no data on this. We have to extrapolate from old data, where obviously the pneumococcal vaccine cannot be given in an acute illness and cannot be given to people with allergy. Short of that, it's anyone's guess. What we have been following is we want to be reasonably sure that there is no active COVID over there. So that's the bottom line. So when they reach the stage of crossing either the 28-day threshold, and we've not necessarily be looking at the RT-PCR because it doesn't make sense over there. After the 28-day threshold, we do offer it to the appropriate subtype who will deserve pneumococcal vaccine. Not everybody, obviously. So the same pneumococcal vaccine conventional indications with extrapolation to COVID and addition of those who are in the fibrotic phase would be the candidates we have been choosing. But, I'd love to listen to your comments on this also, since we are all in it together.
Yeah, and one more thing, this is very interesting. I bring it because it's personal. Nowadays, all your patients come with a lot of information from the internet. So there's this patient who came with, who just before they had COVID had been prescribed polysaccharide vaccine, right? And once they had COVID, they came with this letter to the editor in one of the journals where it was written that polysaccharide pneumococcal vaccine can sometimes potentiate a cytokine like storm or potentiate COVID-19. And they asked me, does that happen? Do you think it happens? What do you think?
No, I mean, I doubt that anything has data at this point. I can't imagine the last 7 months of the pandemic, people have done studies which take, months to years to do. I mean, this COVID vaccine, which was touched on by Dr. Ganguly, is the biggest, I think, medical enterprise in history ever seen. So I don't think there's any data. It's a postulate. Having said that, we are still following PCV13 followed by PPSV, as you mentioned. The interesting part is we have never seen so much vaccine compliance as now. They are showing up for the visits pronto in order to put every possible measure to not either hit healthcare or even remotely be away from the C word.
Absolutely, absolutely. I think the vaccine desks are working overtime. The patients are asking for vaccines now. Okay, so I'll leave you alone for a minute, and I'll go to Vinay. Vinay, influenza vaccine is a lovely talk. I think absolutely to the point. My question to you is, influenza vaccine, can people get influenza vaccine as well as pneumococcal vaccine together?
Because both of them are killed inactivated vaccine, there is no kind of cross reaction with each of them. So if you're not giving the live vaccine of influenza, it is the killed inactivated. Both can be given simultaneously, one to the right deltoid and one to the left deltoid. They can be taken simultaneously. And that is how we program it. If at all someone is willing to take the pneumococcal vaccine, I think they are easily convincible enough to take the influenza shot as well. So it is given on the same day.
Yeah, I think that's a very important takeaway point, because most places practice giving influenza and pneumococcal vaccines at least 4 weeks apart. And I don't think there's any benefit in that. When a patient has come once to a vaccine desk, they might as well get the two together. Absolutely. The second question.
Can we ask Vinay about influenza vaccination in pregnancy? We have a question, Sushmita, on that.
Yeah, I was going to go to that. Influenza vaccine in pregnancy, is there a particular time you should be giving it, or can it be given any time during pregnancy?
Right. Ideal is for us to build up the memory which protects both the mother as well as the child. Ideal is to vaccinate in the 3rd trimester. But I think whenever they come to the healthcare, whenever the first contact happens, I think the influenza vaccination should be given. You should not waste any opportunity. As soon as they come in contact with the healthcare, give them. Because you should not be waiting for ideal scenarios. Protect the mother first. The child will anyway be protected later.
The other things somebody else has asked, patients who already have herpes neuralgia, can they take subunit herpes vaccine?
Bakulesh?
Yeah, okay. Answer is yes. Anybody who has a herpes zoster, it does not mean they have a long-lasting immunity and they are immune for it. So even if you have a herpes zoster of any kind, you should take, and more serious the disease is, more you should be aligned to take that vaccine. So you should take subunit vaccine.
Okay. So
one question to Dr. Datta, Sushmita, about TCV vaccine, the typhoid conjugate vaccine in adults.
Yeah. So the question is, it was very informative, Dr. Datta, that anybody who's not had it to have it. Would you be able to highlight a little bit about the pertussis vaccine, especially having protective effect with COVID-19?
There is no study so far as pertussis vaccine and COVID. But however, if there is an active COVID, you should not give any vaccine, whether it is pertussis or anything. But if in this COVID situation, if anybody comes, you please give the Tdap vaccine. If adults have not received, there is no problem at all. You can easily give it.
That's about typhoid in adults.
Question which Anupam Sibal has asked is regarding the TCV, that is, if typhoid can be given adult and so dose be required. For recommendations so far as typhoid vaccine, especially in USA, because they do not give typhoid vaccine, it is not
We are losing your audio, Dr. Datta.
mandatory vaccine for them. Definitely typhoid conjugate vaccine, only a single. I can't hear you, Anupam.
Now we can. Now we can. Go ahead, please, on TCV.
Can you hear me?
Yes, we can.
I'm just telling that TCB, just only one single dose right now is recommended. WHO also recommends, although in pediatric age group, if you are giving at very early age in infancy, another dose is recommended by Indian Academy of Pediatrics earlier. But the latest guidelines says that by Indian Academy of Pediatrics also done following the TCV. People have found that there is an adequate antibody level which is persisting till 7 years. The introduction of this TCB, which is
Yeah, Dr. Vinay.
Yes, if I have to, I think, simplify and summarize the role of typhoid conjugate vaccine, I think there is no clear-cut indication or guidelines which either support or not support the typhoid conjugate vaccine, but it definitely has or finds favor in patients who are awaiting liver transplant or small bowel transplant. So typhoid conjugate vaccine is one of the helpful vaccines which prevent any sort of complications, because typhoid in these individuals can be catastrophic. So if you have to choose one population where TCV has maximum benefit, that is solid organ transplant, particularly liver and small bowel. Beyond the immunocompromised group, typhoid conjugate vaccine, if somebody is willing to take it, they can, but they should realize that it does not protect against paratyphoid. It's only protective against typhoid. 50% of Indian population or Indian typhoid cases are due to paratyphoid. Even after you take the vaccine, you should follow all precautions, hand hygiene, food hygiene. So in a non-immunocompromised setup, typhoid conjugate vaccine may be plus minus, but in transplant candidates, small bowel and liver, it has great benefit.
Sushmita, questions coming thick and fast. We really have 5 minutes. So if you can quickly go through the questions.
I'll just ask one pertinent question, Dr. Vinay, again. There's when somebody's asking that, lots of patients are on steroids after COVID these days. So how soon, while they're on steroids, can they take flu vaccines?
Okay, it's not about the duration of steroid. Again, like we have been reiterating, it's about the duration after COVID. Once they are within the disease activity, which usually is about 21 to 28 days, do not vaccinate. If they have crossed over, they are eligible candidates for influenza vaccine. Don't go by the duration of steroid, look at the disease activity and then vaccinate.
So Dr. Datta, somebody's, Bhavna,
Somebody,
Bhavesh Shah is asking, it is TCV single dose recommendation in pediatric age group, is it? As one develops enough antibody with one dose only.
yes, right now the recommendation is only one dose, but maybe in due course of time when we know much better about the immunity, whether duration of immunity, we may revise and give it one more dose. There is another question I find in here. Somebody has asked about the tetanus toxoid, that there are some recommendations where every injury you give a tetanus toxoid, which is not true. Tetanus, I have said that if there is a grievous injury or any injury which is a roadside injury or anything where there are chances of infection becomes much more, in that case, only 5 years, within 5 years, if somebody has received vaccine, you don't need to give any tetanus toxoid, neither tetanus immunoglobulin. But if 5 years have elapsed, then only you should give. And this is the recommendation which is being followed by everybody. And this is the recommendation which is by ASIP as well as CDC recommendation. And we also follow the same recommendation.
Sushmita, there's one for Ravi, 81-year-old asthma patient given PPSV 3 years back. When should she be given PCV 13 followed by PPSV 23 after 8 weeks? Would you agree?
Yeah, I think so. I think the 1 year gap is what is important over there. 1 year gap between the last PPSV and the fresh PCV 13, followed by another a 5 year interval between the two PPSVs.
I'm going to answer Dr. Rekha Harish's question. We should be vaccinating adults. Should it be pediatricians or should it be adult physicians? I think pediatricians should look after kids, has medical legal implications. So I don't think pediatricians should be vaccinating adults. From a medical legal point of view, I think that stands to reason. Sushmita, there's one on multiple vaccinations having side effects. Do you want to answer that?
Somehow the questions are, the chat questions are just not popping up in mine.
Here's one. Multiple vaccinations at once, do they cause side effects? Anyone?
No, if they are killed inactivated vaccine, I think the side effect chances are less, but I don't think you can immunize more than 2 or 3 vaccines at a given go. The only side effect that they can experience is pain of being pricked by the needles multiple times. So killed inactivated vaccines given together, the chance of side effect is as good as giving one vaccine at a given point of time.
Vinay, one more question for you. What is the time interval between pneumococcal, Tdap and herpes zoster in someone who's 80 years?
None at all. If they are willing to come take the vaccine in one shot, I think they can get it all on one day. But only thing is the pain tolerance of the 80-year-old person has to be taken into account.
Very interesting question. What about consent for adult vaccination? What's the policy?
Right. I think when they come in for some place like a vaccination clinic, it's an implied consent. But if you're trying to convince someone for a transplant to take vaccine, I think it's always ideal medical legally to ask for a consent and then go ahead. Though I think no guideline or directive says it is mandatory. But if they come for vaccination clinic, I think it's implied consent.
Sushmita, any more from you? Or we bring this to a close?
One last question from me is, a lot of people these days are finding it very difficult or are scared of coming for vaccinations to hospitals, and lots of companies are actually delivering it to the homes. Are there any do's and don'ts the experts would like to say when you are when you're advising your patient who is wanting to take vaccination at home?
The problem is inadequate.
Can I answer this question?
Please, Dr. Datta.
I just want to tell that whenever you give vaccination, you will have to take all due precautions for vaccination, because following vaccination, there can be adverse reactions, which can be immediate reactions in the form of anaphylaxis, shock-like symptoms and all those, and even fainting attacks, which are very, very common. So you will have to be ready with all equipments, oxygen, even endotracheal tube, emboss, bag, epinephrine, everything possible. And that is why it is always preferable that you give it in your own clinic rather than giving it at home. Because at home, all these facilities will not be available. And please remember, in all these immunization clinic, all these facilities, whether it is an adult immunization clinic, pediatric immunization clinic, these are mandatory nowadays to be kept for any eventuality, because people have seen that reactions do occur sometimes, and the adverse reaction, serious adverse reaction, can lead you to a lot of problems, medical health problems later on.
Thank you so much to all our esteemed panelists. Thank you, Sushmita. Thank you to all the speakers. This has been really very exciting. Lots of knowledge has been imparted. And as we bring this to a close, I wanted to remind everyone that please join us on the 10th for what I believe will be the most definite session that has been organized in recent times. It's going to be a global session on COVID vaccination. So we're going to get the US experts to talk about what's happening with the US vaccines. And we know there are 3 or 4 colleagues from Oxford to talk about their vaccine, from Moscow to talk about the Russian vaccine. And then we're going to have a session on the Indian vaccines and on Chinese vaccines. And then what should be the deployment strategy. That session is going to be oversubscribed. So we'll write to you, do register, and see you on 10th. Thank you very much.